So I'm going to sandwich this in between two of the two big components. So we've spent over an hour now talking about self-management and self-management support. And, it's good that we spent over an hour doing that because it's important. It's the biggest chunk of this lecture. I'm going to briefly touch on discharge planning, and then that's going to segue into looking at cancer and survivorship. So I'd really just encourage you to think about any clinical placements that you've done to date. I know some of you are kind of in, doing first year units as well. Some are doing second year, and most of you should be doing third year units. So you will have had hopefully some considerable clinical placement experience in terms of, and I'm just suggesting that you think about any of those who might have been in the process of being discharged or preparing for discharge. Hopefully you might have had that experience already, but it really is a critical point in terms of the patient journey. And often, unfortunately, it's the case that if we don't get it right there, then we can expect to see them come back. So it is really worthwhile, and often we are so busy and so rushed, but it really is a critical thing, point of care that we should really focus on getting right. Particularly in acute healthcare settings, it's a key part of our role. And really, I hope you've heard this before, but planning for discharge should commence from the time someone's admitted. And a lot of the data we're collecting is kind of informing that process of planning for discharge. We don't work in isolation, so interprofessional collaboration is essential. It's fundamental to discharge planning. Ultimately it's about thinking, well, if this episode of care is ceasing and they're leaving this setting, where are they going to? What are their care needs? What are the information needs? Who do we need to share a discharge summary with? Do they need medications, for discharge? Do they need referrals? What support might someone need out in the community? All of these things, it's pretty much like, where's this person going next? Who is going to be their next point of contact in terms of healthcare? So the problems that we do see around discharge are generally caused by poor communication and or poor coordination between hospital-based and community-based healthcare professionals. Not surprising. And hopefully, this is one aspect of my health record in terms of, electronic medical health records, is that information sharing hopefully can be more seamless, where people are happy to have a shared medical record. So just looking at the importance, it is a complex process, so I'm not going to sit here and pretend that it's just simple. It is complex, and there are different stakeholders, different disciplines, and so it does come back to communication and coordination and sharing information. But we are really well placed to be coordinators of care, and so we do need to understand how different health and social care agencies function, and this is particularly in terms of internal policies, but then also external organisations that we might be referring to or sharing information with. This is important. Social aspects of the discharge process have often been ignored or neglected by nurses. Sometimes it may have been a matter of like, well, yeah, we've kind of got this person sorted, we can forget about them and focus on, who's coming in next, which is not so helpful for the poor person then waiting to be discharged. So look, this is an interesting point in terms of a social diagnosis, and look, this is kind of touches on involvement from social work, and this idea of a social diagnosis should run parallel with a medical diagnosis. And I guess at this point I just want to remind us all that social well-being is one of the main components of health as it's defined by World Health Organization. So physical well-being, mental well-being, social well-being, They're the components that together make health as defined by who. So, you know, it's not, and I say this not as a criticism, but sometimes we just think, oh yeah, social workers, they do all the social stuff. And we might just forget that, well, hey, social well-being is a really fundamental part of health, and as nurses, we're health professionals, so we shouldn't just dismiss social issues and social care. So again, just labouring on that, because as I've suggested, I think it's good if you read the psychosocial care chapter this week from your textbook. So really, I think for me, the discharge planning is about not forgetting the person, not forgetting that, not just moving on to the next patient, and, you know, so not forgetting the whole person, that there are social implications for how and where we might leave someone in their journey, in whatever setting we're working in, but also that as they transition to other parts of the healthcare system, whether that's back out in the community or to a different ward, there can be really big impacts on health, purely just through psychosocial issues. Like we mentioned before, they can have a big impact biomedically or physiologically. So we need to take a holistic approach to discharge planning, and that certainly includes making appropriate referrals, or even considering them. It may not be that you end up making particular referrals, but having the discussion, or at least considering what referrals might be appropriate, is really important. And, you know, the fact that we actually do actively plan for discharge rather than just leaving it to the ad hoc, it's really important. So, and the other thing is, you know, sharing, access to information and sharing. So, you know, looking at treatment summaries, discharge summaries, medications, looking at the key things that when have you ever helped discharge someone or prepared a patient for discharge, or if you haven't, then just really stop and think about those key things and look in the literature as well. You know, we're not just going to throw someone out. How can we support them in transitioning out of the healthcare setting? What do they need? Information-wise, support-wise, in terms of referrals, and, you know, medication-wise or equipment-wise. Yeah, so that can certainly involve allied health and different forms of assessment in terms of what's their current health status, what's their level of cognition, impairment, function, are they going to be able to manage at home? Do they need assessment and referral by other allied health professionals? Okay, so I promised we'd get here, and we're now looking at cancer, and, you know, what is it, and looking at survivorship in particular. So this is a really handy report that came out. It's still current. On the AIHW website, they do have a 2018 section, but this report is still current. There hasn't been a subsequent report to supersede this. So what is it? Your textbook, actually this is a good point in time to remind you that your textbook has a really helpful chapter on cancer, and particularly for nurses, implications for nursing practice and cancer care. So the term cancer is used for a group of diseases in which abnormal cells divide without control, and when these cells are dividing, they invade nearby tissue and organs. So, you know, cancer cells spread to other parts of the body, they metastasize, particularly through blood and lymph systems. And, you know, these are known as secondary cancers when they spread in this way, and so that's known as metastatic cancer. So cancer is a leading cause of disease burden in Australia. So this has substantial social and economic impact, not just on the community, but the individuals and families living within the community. You know, so it's estimated that just over 134,000 people will be diagnosed with cancer in 2017. And nearly 20% of the total disease burden in Australia is represented by cancer. So, and you can look again, looking at health expenditure on cancer and non-cancerous tumours. You know, that's a lot of money. And this data is available in that 2017 report. So on average, 367 people will be diagnosed with cancer every day in Australia. That's a lot every day. It's expected that nearly 60% of these diagnosed cases will be represented by males, and 71% for those aged 60 and over. So you can see, again, linking back to our population health, that, you know, gender and age sometimes is relevant in terms of risk. So breast cancer in females is expected to be the most common cancer in 2017. This is talking retrospectively, obviously, followed by, because often that population level data won't be immediately available. So followed by colorectal cancer or bowel cancer, and then prostate cancer and melanoma, skin cancer. So this is an interesting one. So you can kind of interpret that more people are being diagnosed with cancer, that the incidence is increasing, but the mortality rate, you know, on a positive, is actually falling. So less people are dying from cancer, and really what that means is that our survival rate is increasing, which is also good, but it has other implications for us. So looking at an international comparison, so you can see the world average there is just above the middle of that chart, so in the kind of sky blue, and then the other sky blue on the very bottom is Australia and New Zealand. So the MIR, this is the mortality to incidence ratio. I'm going to call it MIR for short. So here the MIRs indicate longer survival. Sorry, the low MIRs indicate longer survival, and higher MIRs short survival. So, you know, if the mortality to incidence rate is low, then there's lower mortality relative to the incidence. So that's why that actually means longer survival. So based on, so they've standardized this MIR in this study, and so based on this standardized mortality to incidence ratio, Australia actually has a higher survival rate, higher cancer survival rate than the world average. So you can see that because we're lower, our MIR is actually smaller than the world average. So lower mortality relative to incidence means that we've actually got a better, you know, we've got a high, relatively high survival rate. So, you know, that's, you know, on one level, you kind of look at that and go, that's good, that's progress, that's a positive. But it also means that in our practice, whatever setting we might be working in, we're more likely to be involved in care of people undergoing cancer treatment or receiving care as a cancer survivor. So this brings other issues to the fore that we need to be aware of, because, you know, we need to look at the term survivor and survivorship and understand what that means, because it doesn't mean that someone may not have a recurrence of that cancer. So before we go and put that into a bit more context, I just wanted to show this example of, you know, someone in their early 20s diagnosed with bowel cancer. And I think it's an important message that, because you know, sometimes, you know, we were talking about traditional care before and generational differences, and sometimes, you know, it might be that someone says, oh, you're too young to get that, don't be silly. And, you know, this is a clear case where actually, you know, if you're really concerned about signs and symptoms, don't let your age kind of, just be a dismissing factor.
So I was first diagnosed when I was 22, and that came about by having a blood vessel burst in the tumour. For at least a year before that, I sort of knew there was something up. I always got like a cold or a flu and was continually having one and the other, and I knew something wasn't right. But I went to my GP and my GP kept dismissing it. At the time I was a chef and I was working in a winery 5 days a week, and outside of that I was partying hard and just living the normal life that a early 20-year-old person does. First I was sent off to have a colonoscopy which found the tumour, and then about a month after that I went in for a ultra low anterior resection, which is where they cut the lower part of the bowel. And in my case I had to take part of the rectum as well. And then I had an ileostomy for 6 months and had that reversed. And then I've had checkups ever since. Going through all this, I've recently worked out there might be a chance of a family history. After I was diagnosed, my uncle was diagnosed, and then I found out that a couple of other family members had also been diagnosed, but it had been kept hidden from the rest of the family. So I'm currently undergoing testing to find out if there's a chance of it being genetic. When I found out that I had bowel cancer, I was quite relieved because I knew something was up and the doctors weren't picking it up, and I was just pleased to hear that they'd finally worked out a reason for me constantly being sick. Being a young person going through bowel cancer, I found it quite challenging to find people to talk to about it. A lot of the elderly patients are in that sort of mindset that we keep our health issues behind closed doors. So just trying to find people and finding the best sort of hints and tips for going through stuff was quite hard. Things are going really well now. I'm back working full time and having fun, doing things as normal. You get the few little hiccups, but nothing major. The best advice is probably to just know yourself, and when you think there's something wrong, just to get it checked out, even if it's just something minor that's constantly niggling at you, as you never know what it may be. I contacted Bowel Cancer Australia early on in my diagnosis, and since then I've worked quite closely with them and have seen how the company has evolved and their peer-to-peer support programs have evolved. I've also been a part of mentoring some people through that and done a lot of interesting volunteer work with them, where I have gotten the chance to meet a large variety of people and seen a lot of interesting activities happen.
So never too young. I just think that's a great example of a well-informed, well-educated person who understands the illness, the treatment, and he's there actively actually supporting, mentoring others who are going through the similar process or similar journey that he went through. And, he mentioned peer support, that he found that particularly helpful. So, that's important to note. I think, the other thing I'd say here is just pause and really ask yourself, what's, looking at this young adult, what's behind the scenes that we haven't seen? What is all the nursing care? What is all of the self-management support that might have gone into producing who we just saw talking then? Because, the surgeries that he had, think about all the education, all of the even survivorship care planning. Because really that's what you're going to be thinking about in terms of your second assessment. He didn't there were some things that, you know, that's just the surface of what he's presenting and talking about, but there's a lot underneath the surface that has gone into supporting where he's at now. And they're all the things that you're going to be thinking about for assessment too. Building on everything that we've just covered in terms of self-management and self-management support. Again, I just think it's great to hear a patient from a health consumer perspective share their story and what their experience has been. So look, you know, stepping beyond bowel cancer itself, but looking at cancer in general and potential cancer pathways. So you can see there at the top, you know, being well in the community, not being symptomatic, and then going from being symptomatic or having screening and having, you know, diagnostics referral from primary healthcare, and then on to more specialised diagnostics and multidisciplinary team involvement. And then, you know, on the four kind of boxes in the lower half, looking where the condition is curable, you've got high level of function, minimal physical impact, and then that can lead directly to survivorship and surveillance, or moving along to the right where it's still considered curable, you can have high physical impact treatment, and then either move on to survivorship and surveillance or relapse and retreatment. So childhood leukemia is an example of that. Moving further along where a cancer is potentially curable, you know, function can be affected, surgery and chemo, radiotherapy. So you can see where function is definitely affected. So, you know, you can have plus, you know, positive or negative really. And so that can feed through to relapse and retreatment. And then looking at the last box where a cancer is considered incurable, so where symptoms on diagnosis, rapid deterioration, and you know that can feed into palliative care, as with the all of the others actually. So these are potential cancer pathways. So survivorship, this is, you know, we need to look at this in depth and from multi-angles. What do we mean by survivorship? So, you know, these terms can be used in different contexts and sometimes the meanings can vary. In practice, when we talk about survivorship, it generally refers to the period after primary cancer treatment ends. Some people argue that, you know, you should consider anyone who's diagnosed with cancer to be a survivor from the time of diagnosis right up until end of life, because that's, you know, considered more inclusive. So in your textbook, Yates actually says that we define a cancer survivor as someone who's living with or beyond their cancer. And here in Australia, generally, as I mentioned just previously, it's generally, you know, people who've completed initial cancer treatment or who are apparently cancer-free. This is a really important point. Do consider family members and friends also to be survivors, because, you know, they certainly experience the effects that cancer has on their loved ones or on their friends. So, you know, cancer does impact on people beyond the patient. So in terms of survivorship, it is a really holistic kind of broad term that we need to understand it. And, you know, in that same vein, each individual, their experience of cancer can be different. But in particular, the end of intensive cancer treatment is frequently reported as, you know, most difficult. Individuals are often unaware and unprepared and left feeling uncertain as to how to recover or reintegrate back into the community. So, you know, it's important. We can't just say, oh, well, you know, you should be happy you've had your treatment and, you know, kind of be thankful that you're not kind of dying at this point. You know, that would be pretty harsh, because it's still a lot of adjustment and a lot of fear and anxiety about recurrence as well. So we all, as a community, workplaces, need to be better prepared for supporting people and just understanding them through a transition of survivorship. So yeah, again, you know, fear of cancer recurrence is particularly concerning and is common. So the use of survivorship care plans has been found to be very useful, but often underutilised. So this is what your second assessment is about, planning for formulating a survivorship care plan. And there is a lot in the literature, actually, if you look. And there are actually toolkits and resources that are available. So we're going to have a look at one example of those, but as far as your assignment goes, you're going to be providing an in-depth kind of discussion about how you would go about planning to develop a survivorship care plan in collaboration. So this is an example of an Australian resource. So this is an online site where cancer patients can go and independently, step 1, step 2, step 3, create their own survivorship care plan. You know, importantly here at the final step, it says, you know, review your care plan with your treating team. So this is almost like the opposite end of the spectrum in terms of, on one end of the spectrum, you might have a health professional go away and whip up a plan and then just give it to the patient and say, there you go. You know, this is slightly towards the other end of the spectrum where a patient is independently developing their own plan. But here at this step 3, it says, you know, actually review it with your treating team, with your health professionals. So rather than either ends of these extremes, what you are actually going to do for your assignment is that you're going to actually develop it in collaboration. So you're going to actively support a healthcare consumer in developing their own survivorship care plan, and you're going to use different models and different content that we've covered to help do that. But this is just an example of a very recent online resource to help people in survivorship care planning. This is a very brief resource on, you know, what do we need to know about survivorship. Actually, I'll be sorry.
I guess I was quite naive and I was still finding my way through the system. And I was very reliant on my specialist until I made this connection with my GP, and me realising that really she's a critical part, she's the cornerstone really in bringing everything together. So I definitely saw that my primary point of contact is my GP in terms of knowing my holistic self, and because it's not just the cancer, the GPs and you know, looks after all aspects of my health. So it was good to have her involved in that aspect.
We've seen many improvements in cancer care over the last decade. I think one of the key areas that we've had increasing awareness of is the need to provide both specialist and generalist care to people who are living beyond their cancer diagnosis.
Survivorship, for me as a general practitioner, is important. And the fact that survivorship means more than treatment of the cancer. It's that ongoing journey with the cancer diagnosis, looking after the patient, looking after the carers as well. And certainly as general practitioners, it's not just the cancer, but other things, heart health, lung health, you know, mental health, all those things are part of survivorship. And for us as general practitioners, working closely with our hospital partners and also allied health practitioners.
Once cancer treatment is finished, not just at that point, but particularly at that point, I think it's a great opportunity to be clear with the patients how much knowledge they have in relation to their particular diagnosis. What I'm referring to here are the optimal care pathways that have been developed through the Health Department and the Cancer Council of Victoria, and they are often a very good guide for what to expect for a patient right through the cancer journey.
I like them to have an understanding of what the late effects of their therapy are, and then setting the expectation as to what's going to be looked at in terms of side effects of therapy, so toxicities to the heart, fertility, sometimes to the lungs, and then also the psychosocial side of things.
In survivorship, some patients may not need a lot of assistance through the hospitals or general practice. They go back to work and they'll live fulfilling lives with loved ones. There are those who may struggle, and although they might be disease-free or cancer-free, there is some trauma post-diagnosis.
There are a lot of things that a patient can do to improve their survivorship care. One of the key things is I think they need to have a GP. And once they've decided on a GP, they need to let their specialist know who that person is. And that way the communication can flow well.
Sometimes patients will, particularly if they feel that their diagnosis of cancer may have been delayed, that's often a real challenge to an ongoing trusting relationship with their GP. Sometimes that perception of delay may be real. Sometimes it may just be that cancers are often very difficult to diagnose, and particularly pick them up early if the symptoms are not very specific. If there are concerns around that, that can have a major impact on an ongoing relationship with their GP. One option is actually to be very open with their GP and talk about what happened to them leading up to their diagnosis. But if they really feel that they don't want to go back to their GP because of concerns about what happened to them leading up to their diagnosis, then looking around to find another GP who they feel they might meet their needs better, who they've had good recommendations from other family or friends, is another option. But ultimately it's about trying to find a GP who you can develop a trusting relationship, and an ongoing continuous relationship is another key aspect of good survivorship care.
It's important to have the continued care of my GP, and since we've got through the rough period of post-operative, and she said to me, right now it's time to start looking at the other aspects of my health that we perhaps had delayed some of those tests, things like a mammogram, or we're starting to tick those off the list now, so that we're back on track with just all my tests up to date.
So patients have a really important role in this, what I think is a partnership of the patient, the specialist and the GP. It's important they ask questions of their specialist and of their GP. Express their concerns and help to understand what exactly it is that they can expect of their specialist, and how their GP fits into their cancer care. There are other members of the practice team that can help as well. Practice nurses are a key part of the practice team, and often can provide some really important additional support for people with cancer, again, during treatment and after treatment. So again, recognising that there's the whole practice team that can support them.
It's always important to remember that it is usually the GP that has referred us the patient in the first place, and they often have more holistic knowledge of the patient than we even manage to gain in the time that we're actually providing specialist treatment. And going forward, the GPs are better placed then to look after the different needs that a patient might have, which are not just specifically related to the fact that they've had cancer.
As a general practitioner, I feel we're very lucky. One of the reasons I got into general practice was being able to look after patients, not just one patient, but in their family, multi-generations. and having that connection, being on top of things for them and their family is something I enjoy about general practice.
So that might seem very GP-centric, but whenever they talk about the specialist and the GP, there are specialist cancer care nurses and there are practice nurses. So they're not just talking about medical, because whenever there's a medical equivalent, there's a nursing equivalent, and there's even specialist prostate cancer nurses. There are we work within those spaces. So, but beyond that, there were some really important messages, I think, to come out of that in terms of understanding survivorship and even just understanding that for many patients, the GP and practice nurses play a really important role in terms of being a hub and a constant throughout a patient's journey. So that's important for us to know when we're collaborating and communicating with patients. But also on the same hand, there are some people who their relationship with the GP may not be close. It may have actually been impacted on by, as was mentioned, a potentially late diagnosis, which a patient may feel disappointed about. So it is important for us to be aware of the different stakeholders and I guess the patient, the person within that context of those stakeholders, where there are positive relationships and strengths, where there are not positive relationships, and what we can do to look at, if someone isn't if they've not wanting to see their GP anymore, then can we help them suggest and find another GP, so at least that they have someone moving forward rather than just feeling that they're alone. So yeah, just an example there. Now, one of the oncologists there mentioned cancer pathways. So this is an example of that. So a cancer pathways guide for cancer patients. So this is an example of a resource that that helps provide information for patients so they can understand, different pathways, what might happen, what might not, what are the different alternatives, because often there are a lot of questions, a lot of anxiety, and a lot of unknown, and that can be very scary. So that's one of the resources that was referred to in terms of cancer pathways. So just wrapping up and summarising, we spent quite a lot of time unpacking what is self-management, and then we kind of dug deeper and looked at different aspects of self-management support, what that is, what it might look like, and two key programs that have been developed to support self-management, the Flinders program and the Stanford model. We touched on some critical considerations when we're planning to discharge a patient, and I guess particularly we were looking, often when we're in the acute setting, we have more frequent kind of acute episodes of care where we're discharging people back out into the community, but this equally, this applies equally to clinic and general practice settings as well. In a different way, and then also cancer and survivorship. So we did spend a little bit less time on cancer and survivorship, but that's because self-management and self-management support are all encompassing really for so many different forms of chronic illness. And we're just beginning to unpack cancer and survivorship as one chronic condition. And after week 5, after our final lecture in week 5, we're going to have a series of online modules, so learning modules in terms of cancer. So really that's just, the end of this lecture is just kind of leading us into looking at cancer in a much more in-depth way.